and dissection. Published by NCBI. Continuing education activity. Head and neck cancer is the sixth most common cancer worldwide. The single most important factor affecting prognosis for squamous cell carcinoma is the status of the cervical lymph nodes. Metastasis to the regional lymph nodes reduces the 5-year survival rate by 50% compared with that of patients with early-stage disease. The American Cancer Society reports that 40% of patients with squamous carcinoma of the oral cavity and pharynx present with regional metastasis to the cervical lymph nodes. This activity presents the causes, pathophysiology, indications, contraindications of head and neck cancer. Objectives. Identify the anatomical structures in head and neck cancer dissection. Describe the indications for head and neck cancer surgery. Review the complications of head and neck surgery. Summarize the importance of care coordination among interprofessional team members to improve outcomes for patients undergoing head and neck surgery. Introduction. Head and neck cancer is the sixth most common cancer worldwide. 1. The single most important factor affecting prognosis for squamous cell carcinoma is the status of the cervical lymph nodes. Metastasis to the regional lymph nodes reduces the 5-year survival rate by 50% compared with that of patients with early-stage disease. The American Cancer Society reports that 40% of patients with squamous carcinoma of the oral cavity and pharynx present with regional metastasis to the cervical lymph nodes. 2. Therefore, the management of cervical lymph nodes is a vital component in the overall treatment plan for patients with squamous cell carcinoma of the head and neck. Head and neck surgery for cancer is a major undertaking with potentially enormous morbidity. Not every patient is a candidate for surgery, and to avoid poor outcomes, it is important to select patients appropriately via a preoperative cardiac and pulmonary workup, in addition to their cancer staging. While surgery has demonstrated superior local control rates, overall survival remains similar with surgical versus non-surgical therapy for many head and neck cancers. The astute clinician must therefore tailor treatment to the individual patient to maximize the quality of life and post-treatment functionality. Removal of the cervical lymph nodes for oncologic reasons is termed a neck dissection, and the surgery is tailored to address the lymph node basins at risk for metastatic spread depending on the site of the primary tumor. Anatomy and physiology. The classification of cervical lymph nodes is according to the system developed at Memorial Sloan Kettering Cancer Center in the 1930s, 3-4. This system divides the lymph nodes in the lateral aspect of the neck into 5 nodal levels, I through V, as described below. The lymph nodes in the central compartment are in category level 6, and those in the superior anterior mediastinum are level 7. The clinical and surgical landmarks for neck node levels are 1. Level 1, submental triangle is level IA and submandibular triangles are level IB, borders are superior, the lower border of the body of the mandible, posterior, posterior belly of digastric, inferior, hyoid bone. 2. Level 2, upper jugular lymph nodes, level IA begins at the posterior border of the submandibular gland and extends to the accessory nerve. Level IIB is the node-bearing tissue bordered anteriorly by the accessory nerve and posteriorly by the trapezius and suboccipital muscles, borders are superior, the base of the skull, posterior, posterior border of the sternocleidomastoid, anterior, lateral limit of sternohyoid, inferior hyoid bone. 3. Level 3, middle jugular lymph nodes, borders are superior, hyoid bone, posterior, posterior border of the sternocleidomastoid, anterior, lateral limit of sternohyoid, inferior, cricothyroid membrane. 4. Level 4, lower jugular lymph nodes, borders are superior, cricothyroid membrane, posterior, posterior border of the sternocleidomastoid, anterior, lateral limit of sternohyoid, inferior, clavicle. 5. Level 5, posterior triangle of the neck, level VA is the tissue above the posterior belly of the omohyoid, and level VB is the node-bearing tissue between the posterior belly of the omohyoid and the clavicle. Thoracic inlet, borders are posterior, the anterior border of the trapezius, posterior border of the sternocleidomastoid, inferior, clavicle. 6. Level 6, central compartment of the neck, borders are superior, hyoid bone, inferior, Suprasternal notch. Lateral. Medial border of the carotid sheath on either side. 7. Level 7. Superior mediastinal lymph nodes, borders are superior, suprasternal notch. Inferior, innominate artery. Indications. Before discussing the indications for neck dissection and the operative technique, it is essential to review the brief background, history, and types of neck dissection. The credit for neck dissection as a curative procedure for cervical metastasis belongs to George Washington Crile from the Cleveland Clinic. 5. In 1900, he performed different types of neck dissections and subsequently described the classic operation of the radical neck dissection, RIND, in his seminal article of 1905 published in the Transactions of the Southern Surgical and Gynecological Association. This operation is the basis of all neck dissections, with subsequent surgeries framed as modifications of this initial operation. Hayes Martin from Memorial Sloan Kettering Cancer Center, who described the stepwise procedure of RND in his classic article in 1951, popularized this operation. However, this operative procedure is not without significant morbidity, as it results in a cosmetic deformity and dysfunction of shoulder movement due to en bloc resection of the accessory nerve, sternocleidomastoid muscle, internal jugular vein, and the tail of the parotid gland. Argentinian surgeon Oswaldo Suarez was the first to describe functional neck dissection in 1963, now called modified radical neck dissection, MRND. He described the removal of all 5 lymph node levels in the neck while preserving the spinal accessory nerve, sternocleidomastoid muscle, and internal jugular vein to limit any functional disability in the shoulder. 6. The types and indications of various types of neck dissection are as follows. 1. Radical neck dissection, RND, lymph nodes from level 1V, ipsilateral sternocleidomastoid muscle, SCM, internal jugular vein, IJV, and spinal accessory nerve, SAN, undergo removal. The parotid tail is rarely included in modern RND. RND is indicated when there is bulky nodal disease in the neck with extensive soft tissue involvement due to extracapsular spread. 7. 2. Modified radical neck dissection type 1, MRNDI, lymph nodes from level 1V, ipsilateral sternocleidomastoid muscle, and internal jugular vein are removed, with preservation of the spinal accessory nerve. Indications for MRNDI is in bulky nodal disease with extracapsular spread involving the SCM and IJ, where the accessory nerve is free of disease. 3. Modified radical neck dissection type 2, MRND2, removal of lymph nodes from level 1V and ipsilateral sternocleidomastoid muscle, with preservation of IJV and accessory nerve. Indications for MRND2 include bulky nodal disease with SCM involvement but sparing the IJ or accessory nerve. 4. Modified radical neck dissection type 3, MRND3, lymph nodes from level 1V undergo removal, with preservation of SCM, IJV, and SCM. MRND3 is indicated in metastatic disease with limited extracapsular spread in the IJ, SCM, and accessory nerve can all be dissected free. 8, 9. Indications. 1. Supraomohyoid neck dissection, SOHD, lymph nodes removed or levels I2, with sparing of IJV, SCM, and accessory nerve. SOHD is indicated in the N0 neck for primary SCC or malignant melanoma where the primary site is anterior to the ear or is located in the lower eyelid, but should include parotidectomy for face and forehead, anterior scalp. 2. Selective neck dissection, SND, removal of lymph nodes in levels IBIV, with sparing of IJV, SCM, and SAN. The procedure is indicated in N0 neck for SCC of the lateral tongue, oral cavity, anterior floor of mouth, or for N1 disease in these primary sites. 10. 3. Lateral neck dissection, also technically a selective neck dissection, removal of lymph nodes from levels 2IV with sparing of IJV, SCM, and accessory nerve. Indications for this procedure are any end-stage neck without significant extracapsular spread for SCC of larynx and hypopharynx, for differentiated thyroid carcinoma, or for melanoma with a positive sentinel lymph node that drains to these nodal basins. Certain primary parotid malignancies also warrant this operation. 4. Posterolateral neck dissection. Removal of levels 2V, suboccipital, retroauricular nodes with sparing of IJV, SCM, and SAN. Indications for this procedure are any end-stage neck cutaneous melanoma with high-risk features or melanoma with a positive sentinel node where the primary site is posterior to the ear. 5. Modified radical neck dissection, as described above. This procedure has an indication for thyroid cancer and upper aerodigestive carcinomas with positive lateral neck nodes but limited extracapsular spread. 11. Contraindications. There are no absolute contraindications to neck dissection beyond those that make a patient unfit for general anesthesia and resection, with one exception: unresectable disease. Relative contraindications include 12, 13. 1. Severe cardiopulmonary disease, COPD with poor functional status. 2. Preoperative imaging showing deep infiltration of the tumor in the prevertebral space, scalene muscles, levator scapula muscle, phrenic nerve, and brachial plexus are not suitable candidates. 3. The primary tumor that is uncontrollable. 4. Distant metastatic disease. And 5. Tumor encasement of the carotid artery. Note: many authors view this as unresectable disease, as resection and grafting does not confer a survival or local control advantage, even if it is technically possible. 14. Absolute contraindication. 1. Fixed neck mass in the deep neck muscles, prevertebral fascia, and or skull base involvement, unresectable disease. Equipment. A standard head and neck surgical pan should include all necessary instruments. Additional, specialized, instruments are at the surgeon's preference and can include McCabe nerve dissectors, nerve hooks, harmonic scalpels, 0.9 mm forceps, Munion right angle clamps, and many others. Personnel. The surgical team comprises an operating surgeon, an assistant surgeon, resident, registrar, another surgeon, or a certified first assistant, scrub nurse, circulating nurse, and the anesthetist. Preparation.